which is an associate professor with the Department of Hematology and Oncology at the University of Chicago, and a lecturer for the Chicago Medical School. Dr. Kozloff is a medical oncologist and president of Monroe Medical Associate, a large medical oncology practice in the south suburb of Chicago. Dr. Kozloff is an attending physician in the Department of Medicine with Ingalls Memorial Hospital, and he serves as a department chair for the Committee on Cancer. Dr. Kozloff did his medical degree at the University of Michigan. He completed his internship and residency in internal medicine at the Michael Reese Medical Center in Chicago, and a fellowship at Simpson Memorial Institution at the University of Michigan. He is certified by the American Board of Internal Medicine. Dr. Kozloff is also a member of the Phase 2 Research Consortium at the University of Chicago. He is also a principal investigator in several national cooperative oncology groups, which probably he will mention prior to his talk. He holds multiple professional membership and affiliation, including the American Cancer Association, ESMO, and many others. Dr. Kozloff has published over 120 publications in various peer-reviewed medical journals, and is nationally recognized for his professional presentation on cancer therapies and research. First, we will have a very comprehensive presentation by Dr. Mark Kozloff, and actually reviewing all the data on Oncotype DX colon in colon and rectum. And following his talk, we will have Professor Brenner with us presenting the Stage 2 Israel Decision Impact Study, and also the design of the Stage 3 study. And I know that many of you have prepared some case studies, so the third part will be case study presentation and open discussion among all of us. So I wish us an interesting and enjoyable morning. Please.
Shalom, good morning. I just would like to thank you for the introduction, and I would like to thank Tiva for inviting me here. I've been here for a week, and I love your country. It's been absolutely fascinating for me and my wife, and we are planning on coming back. It's a beautiful country. So thank you, Tiva. It's really been nice. And I wasn't going to let anything stop me from coming. So we're going to be talking about risk assessment, genetic tools in early stage colon rectal cancer. Before I get started, thank you. I'd just like to give my disclosures. I'm on the Speakers Bureau for Genomic Health, Genentech, Roche. I'm a consultant for Genentech, Lilly, Amgen, and AbbVie. I do research for about 10 different pharmaceutical companies, as well as at the University of Chicago. How I got involved with genomic health is that I was doing a lot of research with Genentech on new drug development for some of their new products. In fact, I was very much involved in the development of Avastin and worked very closely with Herb Hurwitz. A lot of the people moved from Genentech to that of genomic health, and I knew most of the people who did move. And I found it fascinating that, and I think it's the future, that one should be able to look at genomics for making decisions about treatments. It seems to be a much more rational way of doing things. And so that's how I got involved. I'd just like to say that I have no stock in any of these companies. At one time, I owned a lot of Genentech. And I sold all my stock when I started doing research and giving talks, because I thought it would be a conflict. If I was smart, I would have never given the talks, never did the research, and kept the stock. But what can I say? I've actually had a great time doing the research, and it's allowed me to travel throughout the world. So why is it important to do genomics? I think the best answer to that is in breast cancer. And the early breast cancer, when you are node negative, ER positive, HER2 negative, you give hormonal therapy, tamoxifen or an AI, plus or minus chemo. And there's been a number of studies that show that chemotherapy is useful, but it's only useful, it increases survival by 4%. Should everyone get chemotherapy when there's only a 4% benefit? Well, Genomic Health came up with an assay, their Oncotype DX for breast, and basically they showed that they had a predictive as well as a prognostic study, and they've been able to say that not all patients benefit from chemo, and then there's a lot of patients who benefit more than just the 4%. So it is now known in the NCCN guidelines, ASCO guidelines, St. Gallen consensus, and ESMO all suggest using something like, or to use Oncotype DX, because it will tell you who to give, it will help you determine who to give chemotherapy and not. And when one looks at the NICE recommendations, they talk about decision in early breast cancer, that it's prognostic as well as predictive, and it gives the most robust evidence in early breast cancer population about how you can predict and prognosticate and who should or should not get chemotherapy. So how about colon cancer? In stage early colon cancer, can we do the same thing? And certainly, there's a lot of challenges in colon cancer, very similar to breast cancer. We know surgery cures the majority of patients. In fact, you'll have 75 to 80% of the patients will be cured with surgery alone. Absolute benefit one gets when you give chemotherapy, and certainly chemotherapy has been shown to increase the overall survival. It's about 3.5%. So is there a way of knowing or to give a prognosis to tell you that someone's more likely or less likely to reoccur and may or may not benefit a little bit more from chemo? Should everyone get chemotherapy, or should no one get chemotherapy, or should only certain populations get chemotherapy when they have stage 2? Average age in the United States and here is about 70 years old. And these patients do have a number of comorbidities, and so one should be able to find a risk assessment that would, or something to tell us how to treat these patients. Traditionally, we use a number of things. The grade, high grade, low grade to make decisions, lymphovascular invasion. We use stage, T stage, T4 versus T3. We use that of MMR, or mismatch repair gene, which is MSI, microsatellite instability, number of lymph nodes, and traditionally we use all of these to make decisions. But a number of them haven't been that good to make decisions. Certainly T4, worst prognosis, we know that. And so we also know that there are a number of things that we can do to help the diagnosis, or to help the prognosis. And I'm going to go through a few of them right now. Certainly when we look at MMR, mismatch repair gene deficient, it certainly gives a patient a better prognosis. Certainly Ribic, Sargent, Gray, Roth, looking at a number of things. And when one looks at the hazard ratio of MMR deficient versus MMR proficient, one can say that definitely patients who are deficient have a better prognosis in stage 2 patients. And in fact, about 90% or better of these patients will do well without chemotherapy. Approximately 15 to 17% of patients with stage 2 will be MMR deficient. And MMR deficiency is the same thing as having MSI unstable. Now, I have a little story to talk. I teach at the University of Chicago, and every July we get new fellows in. And I always have the fellows go in and see the patients before I do. And this one young fellow came in, and he saw the patients before I did. And he actually saw that the patient was MSI high or MMR deficient. And he told the patient, this is a worse prognosis. You should probably be on chemo. Came out and told me this, and I said I had to, before I sent anybody in for stage 2, I have to tell them this beforehand because they shouldn't tell this to the patient. It is counterintuitive, if you think about it, something unstable, deficient, having a better prognosis. The student learned very quickly, and it took me over an hour to explain it to the patient at that point in time because of the misconceptions. But this certainly does give a better prognosis, and it may tend to give some resistance to that of 5FU. Now, this is something that I find extremely interesting. We always look at, or at least when I first started, I always looked at high grade as giving a bad prognosis. And there are a number of studies now that absolutely suggest that's not true in stage 2. This is the PATEC study, PATEC 3. And if one looks here at a number of markers, stage, grade, age, and MSI high, certainly patients with MSI high do better with a hazard ratio of 0.27. But if we look at grade in stage 2, the hazard ratio is 0.93. That's grade 3, 4 versus 1, 2. In this study, having a high grade in stage 2 patients did not have these patients do worse. In fact, there are a number of other studies that have shown the same thing. And this is looking at the NSABP, the QUASAR, PATEC 3, CALGB, as well as MD Anderson study. And on all of these studies, if you look at the hazard ratios, looking at high grade versus low grade, one cannot say that high grade tends to give a worse prognosis. So I don't use grade to make decisions in stage 2 patients. Certainly high-grade tumors, conclusion, associated with a lower recurrence risk in stage 2 patients, higher risk in stage 3, associated with a lower risk in stage 2, not statistically a predictor of outcome in stage 2. So these are all modern studies that show that grade can't be helpful, not certainly like that of mixed match repair. How about lymphovascular invasion? Now, I differ with our pathologists at the University of Chicago. They swear to me that they can tell lymphovascular invasion and that it gives a worse prognosis. But this was a study done by a number of pathologists at a number of prestige hospitals. And they looked at 50 stage 2 patients. They did both H&E and IHC looking for that of lymphovascular invasion. And the results was that there was a low concordance with H&E, and there was minimal improvement with IHC. And their conclusion from this patient is that intra-observer variability in diagnosis of LVI was substantial and did not improve upon the use of IHC. And certainly this puts this is another thing that I personally don't use to make a decision in stage 2 patients. Certainly T4, worse prognosis, less than 12 lymph nodes, a worse prognosis. I still use those. Certainly perforation, worse prognosis, and I use that as well. So the majority of patients, about 70% of the patients of stage 2 cancers are at standard risk, T3, and they're MMR proficient. The other 30% will either be T4 or have MMR deficiency. About 20% of these patients will be considered standard risk and will have recurrence. Is there a better way to give a prognosis? Will some of these patients have a 35% chance of the cancer coming back? Or will some of these patients have a 10% chance of the cancer coming back? And would you make a difference in your recommendations? And so we're going to go through, I guess that's what we're all here for, is to go through these studies to show that. So this is the development of the 12-gene colon cancer assay. They took about 700 genes. They did developmental studies in with surgery alone, surgeries with 5FU using NSABP, Cleveland Clinic, and they finally came down to a 12-gene assay, basically 7 genes that were used and 5 for references. And then they have done 3 studies on colon cancer to validate this. Certainly that of the QUASAR, done in England, probably one of the largest studies done on stage 2 patients. CALGB 9581, which we'll go through, another stage 2 colon cancer. And the NSABP C07, which is both stage 2 and stage 3, comparing 5FU to 5FU and oxaliplatin. So we're going to go through these 3 studies, and then we're going to go through a rectal study looking at the results. This is the 12-gene cancer recurrence score. Again, calculating the recurrence, there's 7 genes that are used to give a score, and there's 5 reference genes. The stromal genes are genes that give a worse prognosis. So when these 3 genes are present, that gives a worse prognosis. There are cell cycle genes. These 3 genes, when they're present, give a better prognosis. Now, the first time I looked at this, I wasn't sure why Ki67 should give a better prognosis in colon cancer when it gives a worse prognosis in breast cancer. I talked to a lot of my colleagues who do basic research, and they said that's just the way it is. Different cancers, this will be expressed differently and give different prognosis. So better prognosis, worse prognosis, and then there's GAD45B, which is a gene that basically goes to stress, and when present gives a worse prognosis. And then they do this score, and then getting the score, they have this linear outcome that can help give us a prognosis of the chances of the cancer coming back. So the first one was the QUASAR study. This was done from 1994 to 2003. It was done in the UK. And the outcomes of this was looking at surgery alone versus surgery with 5FU leucovorin. It was either using that of the Mayo Clinic or the Rochester way of giving 5FU leucovorin. And that did show a benefit of 3.5%. So people went from about 20% chance of recurrence down to 16.5%, a relative benefit of 20%, an absolute benefit of 3.5%. Is there a way of looking at this? Thank you. Is there a way of looking at this and actually giving a better way of giving the prognosis? And so this is the QUASAR study. Again, chemotherapy, observation, and one can see at 2 years, 3 years, and 5 years, certainly about a 3.5% benefit with a hazard ratio of about 8.8. And in this situation, it was statistically significant. Relative benefit of 20%. So this is the results of the QUASAR study using that of our Oncotype DX. And it shows us that patients in a linear fashion can have as little as a 9% chance of the cancer coming back and up to about a 30% chance of the cancer coming back. And I like this slide or using this curve because to me this is a continuous situation. You can break it up to under 30 giving a better prognosis, 30 to 40 giving an intermediate prognosis, and over 40 is giving a higher risk for recurrence. I personally use this because let's say I get a recurrence score of 10. I go up to here and I tell the patient, you have about a 10% chance of the cancer coming back. Relative benefit of 20%, so the absolute benefit of getting chemo is 2%. Most of my patients will say, for 2%, I don't want chemo. Then, some of these patients may be up at 50 or 60. I go up to here, go up to, could be even as high as 25%. And with a relative benefit of 20%, those patients now have about a 5% benefit of going through chemo. And patients are starting to think, 5%, can be pretty significant. I think I'll go for it. But I've had patients who will want chemo for a 2% or a 5% benefit. And I've had patients who have not wanted chemo for a 2% or 6% benefit. But for some patients, and many patients, this can either give them peace of mind or can give them an idea if they think they should or should not be on that of chemotherapy, knowing the risk of recurrence or the prognosis. They did the QUASAR study, then they looked at a multivariate analysis to what were the factors that were most important at giving you the prognosis. And certainly T-stage with a hazard ratio of 1.83, that means T4 versus T3. T4 giving you a much worse prognosis. Mismatched repair, if you were deficient, hazard ratio of 0.32, a significant improvement or improvement if you were deficient versus proficient. And then the recurrence score, which had a hazard ratio of 1.61. And so that means that as the recurrence score went up, the worse the prognosis was. Now, I want you to remember this number 1.61 because it's pretty consistent in all the studies they have done when they look at that of recurrence scores. Certainly, tumor grade did not mean anything. Number of lymph nodes less than 12 certainly was important. And LVI, which we talked about, certainly wasn't important at all either. So this is the way it's done. And it's important that one can see that one can look at T4, MMR proficient, 13%. T3, MMR proficient, 74%. And MMR deficient was 11% when they looked at the QUASAR study. Now, the first time I used this study, patient came to me and I found out that they were MMR deficient and they had a T4 tumor. So I called up the company and I said, what do I do with this? That patient doesn't really go on any of these lines. And they said, that only accounts for about 2% of the whole population. And they said those patients behave more like T3 MMR proficient. And that patient was up in this area, and we ended up giving chemotherapy. So the T4 in that patient was more important as a prognostic tool than that of MMR. in that particular patient. Now, the other thing I'd like to point out, which I think is very interesting, is that there's some overlap. There is a T4 MMR proficient, goes like this. T3 MMR proficient goes like this. There are some patients who are T3 that have a worse prognosis than some patients who are T4. Now, it's kind of interesting that does this mean that these patients don't need chemotherapy or that these patients do need chemotherapy? And certainly these are the patients that you almost invariably give chemotherapy to. But some of these patients with T3 will do just as badly as the lower risk patients for T4. In the high-risk patients, as we discussed, there's approximately a 4 to 6% absolute benefit. And when they talk about low risk, intermediate risk, under 30, 30 to 40, and greater than 40, low risk, intermediate, and high risk. But again, I prefer using the curve because it's a continuous type of situation. So that study that we just looked at was with surgery alone. It wasn't with the 5FU. The next thing they did is looked at recurrence scores on the patients who had surgery and 5FU. And what they found was that when they looked at low recurrence score, intermediate, and high, that these things were parallel, that they really didn't come together or go apart. So this is why people say that in colon cancer, it is not a predictive study, because if it was predictive, these lines would start together and they would proportionally go out like they do in breast cancer, saying that patients with a low risk score don't benefit at all, and the patients with a high risk score benefit much more to chemotherapy. So when something's predictive, they're not parallel. They either come together or they diverge out. When they're more parallel like this and your risk goes up, that's considered not predictive. Now, I disagree with that term a little bit because I was at a conference one time at the University of Illinois, and I was talking to this guy who's a genomic marker specialist. He says almost every study gives you some type of prediction. Some do it more than others. Because in a way, if these patients, if they're parallel and there's a relative benefit of 20%, it will predict a little bit to your benefit of getting chemotherapy if you use that 20% number. It doesn't change lower and higher. It's always a 20% relative benefit. So the second study, this is a validation of the 12-gene cancer colon in CALGB 9581. I kind of like this study because I had 5 patients on this study. So whenever you put patients on studies, you always like to see how the results were. And this study was a study that was looking at low risk or standard risk resected stage 2 patients. So they excluded obstruction, perforation, positive margins, and T4B. So this group of patients had a better prognosis, and patients either got observation or a monoclonal antibody 17-1A. And I was hoping that the monoclonal antibody would do some good, but this study was a negative study looking at the monoclonal antibody. And so they enrolled this primarily low-risk stage 2 patients. Again, they looked at outcomes and prognosis, and they did, again, to see how patients were, but looking at the characteristics of these patients compared to that of the QUASAR study, there was more patients who were T4 in the QUASAR because they excluded T4B. There was a higher number of mismatch repair genes deficient. There was a higher number of patients over 70. There was less patients who had less than 12 lymph nodes, same amount of LVI, and the same amount of high-grade tumor. Certainly there was some differences. This is a better prognostic group in this study. This is the one thing I forgot to say, and certainly a better prognosis. In the first study, recurrence was about 22%. In this, the recurrence rate was only about 14.6%, and that's because it was a much better prognostic group with higher amounts of MMR-D and less T4. So when they did a recurrence multivariate analysis, what stood out? Certainly the recurrence score again, and when they look at units of 25, they came up with a number of 1.68. Remember I told you to remember the last study, it was 1.6. This is 1.68. Different study, different population of patients, but the benefit certainly is almost exactly the same of using the recurrence score. It gives you about the same amount of prognostic information, 1.68. They also looked at T-stage, MMR status, number of lymph nodes, tumor grade, and LVI. But certainly a recurrence score, again, shows some value in prognosis with the same hazard ratio that we saw in the QUASAR study. When they look at low risk, intermediate risk, and high risk, about 22% of the patients were that of high risk, with their chances of having a recurrence being somewhere between 16% and 26% at a 21% probability. But again, this was a very selected group of stage 2 patients. That takes us to our third study. And so just to tell you that the first, adding up the numbers of these 3 studies, we're now looking at some 7,000 patients or 6,000 patients at validating this study. So this is a validation looking at NSABP C07 as a predictor of recurrence in stage 2 and stage 3 patients treated with 5-FU leucovorin as the standard versus that of 5-FU leucovorin and oxaliplatin was the investigational arm in this study. For patients with stage 3 colon, practice guidelines recommend that of either Xelox or Fofox. And when one looks at the benefits in stage 3, the majority of the benefit comes from 5-FU or Xelox. You have about a 22% chance of decrease in the recurrence rate in stage 3 patients. About 15% of that comes from 5-FU or that of capecitabine. 7%, somewhere between 6 and 7%, comes with that from oxaliplatin. Certainly the most toxicity we see from Fofox or Xelox is neuropathy. And so the question that comes up is, can this study be used to determine who should or should not get oxaliplatin? This study was 2,409 patients. They were able to get 77% where they could get tumor tissue. They only took half of the tumor tissue and half the patients to study this in that of using the 12-gene assay. They're saving the other 50%. And I'm told, I may be wrong, but I'm told that the other 50%, they're going to have another gene set that they're looking at that they think will be very predictive of benefit or non-benefit of oxaliplatin. So they're saving half these patients to basically look at another gene set. So they finally got a cohort of 929 patients, evaluable patients 892, significant amount of numbers. And then they looked at the demographics, Caucasian, about 90%, females 42%, Age, again, about 58, only about 17% over the age of 70. Again, almost all the every randomized study I've ever seen in colon cancer looks at the average age of about 58, 59. Average age I see in the office is about 70. So I always wonder, does this always apply to my 80-year-old patients? Stage 2 patients, 30%, 3AB, 45%, 3C, 25%, T4, about 5%, T3, T4, about 85% for stage 3. MMR status, about 17% is what we've seen in stage 2. MMR deficient is less in stage 3. It's only about 8%. Nose examines over 12 is about 64%. I don't know, just a quick show of hands. In the United States, I think we get over 12 lymph nodes about 90% or better of the times. Is that what we usually, what's the number in Israel? Over 90%? Yeah. When you start looking for it, then you find it. Okay. About that many. Okay. So look at the recurrence score, the chances of recurrence. Recurrence score here is per 25 units, 1.96. Not that much different. Not that much different than the other two studies we've just talked about. They were 1.68. So again, we have a third study in which we're seeing very consistent results at a prognostic study to tell us the chances of recurrence. Certainly, stage 3 patients had a worse prognosis than stage 2. Stage 3C significantly worse than stage 2. And there was a benefit of adding oxaliplatin at about a hazard ratio of 0.76 or a relative benefit of 24%. So how does this look when we do it? And I kind of, again, I like the graphs. To me, it does better than when I see these high, intermediate, and low, because we have stage 2 here, we have stage 3 here, stage 3C. We have 5-FU is the solid, 5-FU and oxaliplatin is the dotted line, and one can see that there's a relative benefit of giving these drugs, but how much should one go through if you're low-risk stage 3 versus a high-risk stage 3 versus stage 2. Now, when I looked at this the first time, I said to myself, here's some patients with stage 3 that have the same prognosis as stage 2, and it's pretty low. Why should those patients get oxaliplatin? Now, I have a partner at the University of Chicago. He looked at this totally different, which always amazes me how people look at things. He looked up here, and he says, wow, I have some stage 2 patients that do just as poorly as some stage 3 patients. These patients should get oxaliplatin. So we debated this. So you get 2 Jewish guys in a room and you debate and you get 3 opinions. But it was a good debate, but certainly one can use this to decide if one should make a decision. Now, I'm going to give a short story. I don't want to bother you with all these sidetracks, but the first patient I used this on for stage 3 was an oncology nurse who worked at our hospital. And so she was a nurse who gave Fofox or Zelox to a number of patients. She was a stage 3B. And she said to me, I don't want to get oxaliplatin. I'm not married. The only thing I love doing in the world is playing the piano, and I don't want to stop playing piano. She had positive notes. I really wanted to give her oxaliplatin because I wanted to maximize her chances of doing well. We did this test, and she was down here. She got Xeloda by itself, or capecitabine, and that was over 2 years ago. And she's disease-free and doing well, playing her piano, working on the floor, telling everyone how good of a doctor I am. But I feel very good that we actually did this test. It's the first time I used it in stage 3 patients, on a patient who kind of insisted that she didn't want oxaliplatin. I used the test because I thought I was going to be able to talk her into oxaliplatin. That confirmed to her that she shouldn't be on it. Okay. So now we have this recurrence score in 3A and 3B. We find that we have low, intermediate, and high. When we look here, 5FU for low, there's almost no benefit of adding oxaliplatin. Intermediate, a benefit goes from 19% to 30%. High risk goes from 31% to 43%. So one can use this. Number of events are not great. So in any individual, you don't have a lot of numbers. But one could probably say in the low-risk patients, why should they get oxaliplatin? Okay. This is, again, our multivariate analysis. Not going to belabor this too much, but looking at per 25 units, a hazard ratio of 1.57. Remember, I told you to remember 1.6. We now have 3 studies, many patients, that show that using the recurrence score can be prognostic with a hazard ratio of about 1.6. Okay. So how could this be used clinically? And this is a study, and you're going to hear about your own study in a couple of minutes. I'll try not to belabor this too much, but this was a validation. How can one use this in making decisions? And this was done by the Mayo Clinic Cancer Research Consortium. And what they did is that the medical oncologists looked at T3N0 patients who were eligible. They had a questionnaire. They said, this is how we're going to treat the patient. Then they got the Oncotype DX MMR testing. If the patients were MMR deficient, they were not included. If they were MMR proficient, they had a post-questionnaire. Would you change your treatments? Would you treat them the same? How would things go? How does it match up? And the results of this showed that this is the end results, 63 of 141 patients, the recommendations changed, 44.7%. In 47 patients, or in 1/3 of the patients, there was less treatment. And in 16 patients, or 11%, the patients got more treatments. Now, in our country, insurance companies love that, but it made a difference to how patients were treated using a recurrence score and giving a better prognosis, and there was less chemotherapy given. What struck me is that a number of patients got less oxaliplatin for stage 2, and I think that is the way to do it, not to get oxaliplatin. So this could be a new paradigm. Patients who are at very high risk should get considered chemotherapy. Patients who are at very, very low risk, not to do any, just observe. Patients who are at standard risk, one can use the 12-gene assay to get a better prognosis and figure out a relative benefit that may help patients make decisions about their treatment. Okay. This is the last study that I'm going to go through. It is a validation of the 12-gene colon cancer recurrence score in stage 2 and 3 rectal cancer. And I find this to be an interesting study. I have to be honest with you that we have not used this at the University of Chicago yet for our rectal patients. I find it interesting. We probably will use it on some patients, but when a patient's T3 or T4, we usually, N1, on clinical studies, we almost invariably put them on radiation and chemotherapy as a standard prior to surgery. But this will put some question marks in some of our minds. This was a Dutch study looking at total mesothelial rectal surgery. It had 1,861 patients. 518 patients had surgery alone, stage 2 and stage 3. Patients had radiation therapy and then had surgery. What they did when they looked at the recurrence score, they only looked at the top one, patients who had surgery alone, and they were able to recover about 59% of the available tissues and then look at outcomes. And when they looked at this for patient characteristics, I think this was similar results as the whole parent study. As the stage went up, resection margins positive went up. For stage 3C, 52%, stage 2, 16%. Certainly the grade as well went up from 16% to 49%. So there was some, and this was what was seen in the whole parent study. When they looked at specified analysis for recurrence, this recurrence score significantly increased the effects of stage of resection and looked at recurrence. And I'd like to show you this again, that recurrence score here per 25 units, 1.57. The fourth study in which we're seeing a very similar hazard ratio for the benefits of predicting a recurrence in these patients. Statistically significant. Certainly patients who were stage 3A versus 2 did worse. Patients who were stage 3 versus 2 did worse. What amazed me is that patients who had R1 resections did not do that much worse. And it was not statistically significant. So positive margins, they did slightly worse, but not that much worse. This is looking stage to stage, interaction of the recurrence score with stage. I'd like to point out that of stage 2, which is T3 and 0, and these are patients who only had surgery. This is low, under 30, intermediate, 30 to 40, high, greater than 40. And it really gives us a difference in outcomes in these patients. It really gives us a significant breakdown of the recurrence rate. Stage 3B, also somewhat helpful. Low risk, intermediate risk, and high risk. Certainly if you look at these versus low risk, there is a difference. Not as good as stage 2, but some benefit. Stage 3C patients, I would just look at these curves and tell you I wouldn't use it to give me a prognosis, a difference in prognosis in stage 3 patients. This is accounting for interaction of stage and non-linearity. So recurrence scores resulted was significantly associated with the risk of recurrence in stage 2 and 3A and B, which I just showed, not so much for stage 3. And certainly looking in a multivariate analysis controlling for that of resection margins. There was a high variability, or a wide range of these risk assessments. Looking at that of stage 2, going anywhere from just 1 or 2% up to about 40%. In stage 3A and B, about 10%, going up to about 60%. So there is a wide range of outcomes using this recurrence score. This is our multivariate analysis again, looking at recurrence scores, and certainly again for stage 2 and 3A and 3B, there is some significance in using it as a recurrence predictor. Certainly stage 2, much more significantly than stage 3A or B. Not useful for stage 3C. I find this interesting. It really didn't help us looking at that of overall survival or that of disease-free survival, but when we looked at specifically cancer, rectal cancer-specific survival, it was helpful. Approximately 50% of the patients died of something other than cancer. So it's not going to be too helpful looking at overall survival, but cancer-specific survival, certainly the recurrence score can be helpful. Again, this is looking at stage 2 patients, which I think is very significant. Low 5-year recurrence score, 12%. 5-year rectal cancer mortality, 5%. This is pretty low. I would say in the intermediate and high patients, I would probably want to treat those patients because the significance of getting both local recurrence, distant recurrence goes much up, and I would probably want to treat those patients with chemo and radiation. But I would be tempted at not treating these patients with chemo and radiation. So what can we say in conclusion? And I really looked at these 4 studies and the hazard ratios. I think they're very consistent in giving us a risk assessment of the recurrence rates for colon rectal cancer. And one could potentially use that in making clinical decisions about treating or not treating with chemotherapy, adding or not adding oxaliplatin, and it could potentially help us with that of rectal cancer as well. Consistent findings in colon rectal cancer suggest that similar biology is associated with recurrence risk, I think is the underlying bottom line. So I would like to thank you for listening to me today. I want to thank you for coming in on your day. I think it's your day off, so I really appreciate it. And most of all, I appreciate the invitation from coming here because I've had a great time. Thank you.
Now we will have Professor Glenn present the Israeli